Management of supraventricular tachycardias. May 31, 2008. Sandeep K. Jain, MD. Cardiac electrophysiology, history pattern of symptoms, palpitations triggers syncope. Caffeine, tobacco, alcohol. Nasal decongestants. Emotional events. Syncope. Physical exam avenue dissociation split S2. More than one arrhythmia can yield similar exam findings, so not as useful for making a diagnosis. SVT mechanisms: sinus tachycardia, atrial flutter, atrial fibrillation. Junctional tachycardia, atrial tachycardia. Avenue node reentry tachycardia, AVNRT. Accessory pathway mediated tachycardia, AVRT. ECG RP waves present. What are atrial and ventricular rates, and are they the same? Regular or irregular? Is the PR or RP constant? Carotid sinus massage increases vagal tone. Sinus slowing and prolongs avenue nodal refractoriness. Sinus talk gradually slows then returns to rate prior to massage. AVNRT or AVRT can terminate at AF and AFL. Ventricular response slows. Sinus tachycardia, gradual change in heart rate, normal P wave contour. Constant PR interval before each QRS unless there is avenue block, long RP. Carotid massage or Valsalva will gradually slow rate and then resume to original rate. Almost always secondary. Management is to treat underlying cause. Rarely, inappropriate sinus tachycardia, in which case beta blockers, CA blockers can be utilized. Sinus node reentry tachycardia is abrupt in onset, anxiety related, and can be treated with RF ablation. Atrial flutter, macro reentrance rhythm in the atria. Usually associated with underlying heart disease. Typical flutter is in the right atrium and can travel in counterclockwise and clockwise directions. Incisional scars from prior cardiac surgery, congenital abnormalities. Atrial rate is typically 250 to 350 beats per minute. Ventricular rate of 150, look out for 2 to 1 flutter. Counterclockwise. Clockwise. Diagnostic maneuvers: adenosine. Atrial flutter, management. Rate control, anticoagulation. Beta blocker, CA blocker, digoxin. Stroke risk likely not much different than atrial fibrillation. Cardioversion. DCCV with low energies possible, 5100J. Ibutylide successful in 60 to 90%. Prolongs QT and need to be monitored 4 to 6 hours. Post-administration. Overdrive atrial pacing if available. Atrial flutter, management. Antiarrhythmics. Class IA agents, convert and maintain sinus rhythm. Class 3, amiodarone, sotalol, dofetilide. Need to have avenue nodal agent on board to prevent 1-to-1 flutter. Flutter rate slows and allows 1-to-1 conduction. Class IA agents also have a vagolytic effect, flecainide administration. Atrial flutter, management. Radiofrequency ablation. High success rates for typical flutter. Atypical circuits can be approached percutaneously with advanced mapping systems. Significant proportion of patients eventually develop atrial fibrillation, indicating underlying substrate is the issue. Atrial fibrillation. Multiple wavelets propagating in different directions. No effect of atrial contraction. Most common arrhythmia. 1% of those older than 60. 5% of those older than 69. Multiple causes, consider mechanical such as from an RA catheter. Atrial fibrillation rate versus rhythm control and decoagulation. No benefit of either if asymptomatic. anticoagulation, congestive heart failure, hypertension, age greater than 65, diabetes, stroke. Maintenance of sinus rhythm does not necessarily eliminate stroke risk. Atrial fibrillation rate control conversion. CA blocker, beta blocker, digoxin. Conversion. DCCV. Class I, procainamide, flecainide, propafenone. Class 3, amiodarone, sotalol, both poor as converting agents, ibutylide. Maintenance of sinus rhythm. Same as above plus dofetilide. 50 to 70% efficacy at 1 year. RF ablation is an emerging tool. Atrial tachycardia rapid, focal discharge in the atrium. Rate generally 150 to 200 bpm. P-wave contour different from sinus. P-waves generally found in second half of tachycardia cycle, long RP, short PR. Most commonly in those with structural heart disease but also seen in those without any cardiac abnormality. Atrial tachycardia adenosine response. Terminates tachycardia with an R wave. Or tachycardia persists with avenue block. Atrial tachycardia, management. Beta and CA blockers. Class I antiarrhythmics in normal hearts. Class 3 antiarrhythmics in abnormal hearts. Radiofrequency ablation for those who are refractory, intolerant to medications. Avenue node reentry tachycardia. Regular, sudden onset and termination at rates between 150 to 250 bpm. QRS usually normal unless aberrancy is present. Reentry within the avenue node. P-wave seen just prior to or just after the QRS complex, short RP tachycardia. Usually occurs without any structural heart disease. Avenue node reentry tachycardia. Antegrade limb is the slow pathway. Retrograde limb is the fast pathway. Baseline. Avenue node reentry tachycardia. Of 2 to 1. Avenue node reentry, management. For adenosine, vagal maneuvers, carotid massage. CA, beta blockers, rarely antiarrhythmics. Overdrive atrial or ventricular pacing. RF ablation is usually treatment of choice for chronic management, cost-effective and high success rate, tilde 1% incidence of avenue block requiring permanent pacemaker. Accessory pathways. Muscular connections outside of the specialized conduction system connecting the atrium and ventricle while bypassing the avenue node. Can be manifest, WPW, or concealed, retrograde-only conduction. Concealed pathways not apparent on ECG. Manifest pathways have a delta wave representing pre-excitation of ventricular tissue prior to activation via the His-Purkinje system. Concealed accessory pathways. 30% of people with SVT referred for EP evaluation can present with syncope. Normal baseline 12-lead ECG. Orthodromic atrioventricular reentry tachycardia is the mechanism of SVT, down the avenue node and up the accessory pathway. We'll often see a retrograde P wave during SVT, short RPM less slowly conducting pathway. Orthodromic avenue reentry tachycardia. Most common arrhythmia with presence of an accessory pathway. Macro reentrant circuit in which the impulse travels down the avenue node and up the accessory pathway. Narrow QRS interval. Accessory pathways. Accessory pathways. Response to BBB aberration. Does VA interval increase with development of BBB? An increase in VA interval indicates the presence and participation of a bypass tract on the side of the blocked bundle. Concealed accessory pathways. Same management as for avenue node reentry. RF ablation should be considered early in symptomatic patients. Atrial fibrillation in conjunction with a concealed pathway does not pose a risk of sudden death in 4CA blocker, not contraindicated as the pathway does not conduct antegrade. Pre-excitation syndrome, WPW. WPW syndrome is when tachycardia is associated with a finding of a delta wave on the ECG. Incidence is 1.5 per thousand. Epstein's anomaly associated with multiple bypass tracts. Baseline ECG findings. PR interval less than 120 ms. QRS greater than 120 ms with a slurred, slowly rising onset, delta wave, and usually normal terminal portion of QRS. Secondary STT changes in opposite direction of delta wave. Accessory pathways. Left free wall most common, then posteroceptal, right free wall and androceptal. Pre-excitation syndromes. Pre-excitation syndrome, WPW. Most common tachycardia is orthodromic AVRT as seen in concealed bypass tracts. Major difference is the capacity for anterograde conduction over the pathway during atrial fibrillation, 15 to 30%, or atrial flutter, 5%, and thus the rare incidence of sudden cardiac death. Some children lose conduction in the pathway but usually persists if present at age 5. Pre-excitation syndromes. Pre-excitation syndromes. WPW, treatment. ECG abnormality only without arrhythmias may not require EP evaluation. Symptomatic patients should receive treatment. Ablation, electrical or surgical. Good success rates but with procedural risks. Pharmacologic. Drugs prolong conduction and are refractoriness in the avenue node, accessory pathway, or both. Some agents can suppress premature atrial contractions which can induce arrhythmias. WPW, treatment prolong conduction time and refractoriness in avenue node. Adenosine, verapamil, beta blockers, digoxin. Prolong refractory period in accessory pathway. Class A and IC drugs. Affect both AP and avenue node. Class IC drugs, amiodarone, and sotalol. WPW, acute episode. Normal QRS, regular RR intervals, retrograde P waves. Approach same as ignort, vagal maneuvers, adenosine, 4CA blocker. Note, atrial fibrillation can occur after drug administration, so external defibrillator backup should be ready. Atrial fibrillation or flutter with irregular RR intervals and abnormal QRS complexes. Agents which affect avenue node and pathway, procainamide with beta blocker. Any signs of hemodynamic impairment, electrical cardioversion is initial treatment of choice. WPW, treatment drugs not to use in AF/AFL with WPW. Digoxin has varying effects on the accessory pathway and can shorten refractoriness and speed ventricular response to atrial fibrillation. 4-lidocaine can also increase ventricular response rate. 4-verapamil can precipitate ventricular fibrillation in this circumstance, may not happen with oral catecholamines.